to introduce our presenters, Dr. Elena Caron from Bonheur Children's Hospital and Dr. Partha Ghosh from Boston Children's Hospital. And Dr. Caron, if you want to take it away.
Okay, thank you. And thanks for asking us to comment and lead this discussion on something that's very important to all of us. So the program learning objectives are to appreciate the need for early intervention for children with neuromuscular disease, identify signs and symptoms of pediatric neuromuscular disease, adoptive vigilance in observing the patients in daily clinic practice for signs of neuromuscular disease, and to recognize the signs, utilize testing and clinical workup for suspected neuromuscular disease, and know how to locate neuromuscular disease resources and experts to guide the referral, diagnosis, and care. The program agenda is number 1, level setting. So why is this important? Number 2, clinical profiles. What are the red flags and appropriate testing? Number 3, case studies, how to test your knowledge. 4 is a summary of the resources, and we'll end with questions. So for level setting, who is this for? Why is it important? Vigilance is needed to recognize neuromuscular diseases, and that's important because there are so many types of neuromuscular disease throughout the lifespan, but many are identifiable in infancy and childhood, and subsequently there are interventions and therapies that can make a big difference in the disease course and comfort and accommodations of the person. So there are specific patterns that we hope to convey through this lecture so that anyone in the community providing care can recognize that, make appropriate referral. And we also hope that neuromuscular disorder experts can be encouraged to reach out and be accessible and form good communication networks with people. You can go to the next slide. How to recognize the red flags. This benefits why is it important for us to recognize those? I think all of us who work with families know that when people don't have a diagnosis, but they are noticing symptoms that are concerning, their anxiety goes up. We want to reduce that so they can use their energy for important things like interventions, getting them to the correct specialties where they can improve the quality of life, know about treatments that are available and show efficacy for specific disorders, begin accommodations in school for developmental appropriate activities, and hopefully to make this network an alliance between primary care and MDA clinics where all specialty care is coordinated and collaborating with the primary care. So this is an audience poll. At first, we wanted to see if you can, where the knowledge is at this point with all of these diagnoses listed on the right of the screen, how you feel with those. So you can go ahead and gauge a response to each one of those questions. Give you time to respond and see where most of the participants are responding. Okay, so you can see for number 1 question, we'll just look at those responses about most people didn't respond, but some said they were highly confident, and most people didn't respond to any of them. Maybe they don't have access, but we can move on. Those are the things we hope to address. So this slide is about when to suspect neuromuscular disease. What are some of the common core features? And we're hoping to relay to you what we see so often, but are rare diseases, and we know you're not seeing that much of it. But usually it comes out in some form of abnormal muscle function, some type of motor dysfunction. So in the clinical history, you may hear that they have a gross motor delay, difficulty keeping up with peers, frequent falls, toe walking, some type of exertional muscle pain, or a family history, and the family's concerned about this child, will they inherit something? Some of the muscle symptoms or motor symptoms are fixed and some are episodic. Those that can be fixed, you would see that in an impaired gait. The gait just looks unusual, waddling, off balance, joint contractures, something called a pes cavus foot deformity. So the shape to the foot is abnormal, high arch foot, skeletal deformities such as scoliosis, muscle weakness, and respiratory difficulties. Some of the muscle symptoms that are episodic are rhabdomyolysis. When they engage in exercise, they don't tolerate it, they get muscle pain, or they get weakness. And in between those spells, they look normal. On exam, you may see that the face looks weak, expressionless, ptosis or weak eyelids, the eye muscles don't move. The baby that lies in a frog leg posture, reflexes absent or hard to get, or weakness and dysfunction of the bulbar muscles. That's in the brainstem, which comes out on exam as trouble swallowing or breathing or neck weakness. Some things you may hear from parents are that they say he just doesn't seem to be keeping up with his friends. He runs out of steam. He holds onto the railing of stairs, needs support to get up from the floor. The child's feet look different, have high arches, which are similar to somebody else in the family. Another child may look sleepy all the time or tired even when they aren't because they have droopy eyelids. Another child may be described as looking much older, like an old person getting off of the floor or getting out of bed in the morning. And if you do see these things on exam or in history and you think you may have a patient with neuromuscular disease, tests we think are important and really helpful that you could do or to start with typically is the CK. If you think it's a motor problem, you want to test the muscle enzyme, because if it is an abnormal test, which is very elevated, 5 times normal, you would want to consider a referral to a neuromuscular specialist to evaluate that patient further. You have to remember in the first week of life of babies, CK may be elevated non-specifically. Other tests, such as genetic testing, if the baby's phenotype or clinical exam looks very typical for specific disorders, you can go to the gene testing, and many of those genetic tests now are commercially sponsored or no charge testing. Other tests that we think about that are helpful, that help you understand where the weakness is coming from, are tests like an EMG nerve conduction study, typically done by a neurologist to see is it the nerve or muscle dysfunctioning causing weakness. MRI and ultrasound look directly at nerve and muscle and can also help determine which one it is. And muscle biopsy, I think most people think of that when they think of it maybe is the muscle. Should we do a biopsy to understand? Sometimes the gene test is done first, and actually now more commonly the gene test is done, but sometimes a biopsy is still required. So this slide goes through some of the most common neuromuscular disorders, which is the content of the rest of the lecture. And we'll start with the first one, which is called Charcot-Marie-Tooth disease or hereditary neuropathy. These are genetically inherited disorders of the nerve, and they are very common, 1 in 2,500 children and adults. They can have onset very young in infancy or in adulthood, and they have many different gene mutations. The most common is PMP22 duplication, but that is one reason why knowing the exam findings can be so important, because you may not be able to find the gene causing it, but if you know this patient has that classic exam that's concerning for a nerve or muscle disease, you can go ahead and refer them. We can do the work of the gene testing. Next is Duchenne muscular dystrophy and Becker muscular dystrophy, which affects 1 in 5,000 males. Onset of symptoms is between 2 to 5 years old, which can be later in Becker because it is the mild form. It's due to a mutation in the Duchenne muscular dystrophy or DMD gene, and it is X-linked inherited. Myotonic dystrophy is 1 in 8,000 people worldwide. Onset of symptoms is a range again from birth to juvenile, and the gene responsible is the DMPK gene with autosomal dominant inheritance. Limb-girdle muscular dystrophies are very rare and varied in their both genetic etiology and phenotype. They are also autosomal dominant or recessive, but the point of this whole presentation is to give you those patterns of weakness. So even though they may be rare, difficult, we don't have to find the specific one. We just want to know, do they have suspicion for a neuromuscular disorder? And then we can pursue looking into it further. Spinal muscular atrophy, or SMA, is another very common type. 1 in 10,000 births for incidence, about 1 to 2 per 100,000 for prevalence. Onset is usually before 18 months of age, and this is a mutation in the SMN1 gene. And finally, congenital muscular dystrophies or congenital myopathies are also very rare and have multiple different genes involved, but the onset is typically at birth. We'll go into some clinical profiles and red flags. So we'll start at the younger age spectrum with the infants, and typically we refer to these as floppy or hypotonic infants. The presentation or things that we notice on exam are the hypotonic posture, most typically the frog leg posture with the legs splayed out. There's not much muscle bulk. Babies don't have a lot of muscle bulk anyway, but usually you can tell their muscle is thin and soft. Limb girdle pattern weakness refers to a proximal weakness, so the shoulder girdle or the hip girdle. The trunk is typically weak with a rounded back, not moving much in the trunk, has to have a lot of support when lifted. Reflexes are reduced or absent. The face can be weak, not much expression. Eyelids are droopy. Neck is weak with difficulty swallowing and difficulty breathing. The eye muscles may not move well, so you may notice even when you move the head, the eyes don't move. But very strikingly, they're alert. They're not encephalopathic, so they tend to look and cry and respond and be interacting with the environment around them, but they are profoundly weak. Some prenatal symptoms are that of the decreased fetal movement or fetal akinesia and polyhydramnios. The most common reasons for these are these ones we think about all the time: some central nervous system etiology, infection or metabolic disorder. But if those are ruled out, then you do want to look into the neuromuscular disorders, specifically for floppy infants, SMA type 1, congenital myotonic dystrophy, and the list goes on. For floppy infants, one thing we want to point out is that for most states, we have newborn screening for SMA, but not in every state. So we want to remember that SMA has been the most fatal genetic disease of childhood. And now we have treatments for SMA approved. So the earlier the treatment, the better the prognosis for the child. The reason that is important is state newborn screening should catch every newborn, but we know that about 5% will not have the specific mutation that newborn screen tests for. So pediatricians will likely be the ones, or primary care, to encounter that baby who's getting very weak. And when they do see them, it is important to check also reflexes to see if they have SMA. The earlier the FDA approved treatments are started, the better prognosis for the infants. SMA has different subtypes, and obviously the ones we're talking about that we need to recognize on newborn screening are the type 1 SMA. They are the most severe in weakness, and they have a dysfunction in anterior horn cells. All of SMA does, and which causes progressive weakness. So type 1 is characterized as being non-sitters. They have weakness onset early on, usually at 4 to 6 weeks of age, but all of them have weakness by 6 months of age in this type. They have decreased leg strength, reflexes are absent, they have a weak cry, poor head control, they do not achieve sitting, but again, they have this cognitively alert system. You can tell they're very alert and not encephalopathic. Type 2 SMA does achieve sitting and has a weakness onset before 18 months of age. They also do not have reflexes. In all of SMA, the CK can be mildly elevated, but not to the degree of Duchenne. So maybe in the 100, 200, or up to 1,000, but not more. The weakness is always more proximal and always in the lower extremities more than upper. Type 3 SMA actually learns to walk. So these children have gained the milestone of walking, but their gait may be waddling forward, showing that hip girdle weakness, and their CK can be a little more impressively elevated. They may have decreased reflexes, but the reflexes are present, and again, are cognitively doing fine. So back to what the description of the floppy infant looks like, and that in particular to SMA. These are babies with spinal muscular atrophy. And you can notice the frog leg positioning, how they're not moving their arms much, the thin muscle bulk. The babies on the far left have actually had time to develop what we call a bell-shaped chest because of the loss of muscle in the chest compared to the diaphragm. They also, you can tell, need some head support to turn the head or to put the head midline. So they have neck weakness as well. The baby in the middle shows a good example of the head and neck weakness with pull to sit. The baby or the young girl on the far right with SMA type 2 has achieved sitting, but she cannot stand without support. But you can see her thin muscle bulk. She probably can't raise her arms over her shoulders, so she has proximal weakness too. The workup for a hypotonic infant with suspected neuromuscular disorder, you do want to check a CK. If it's very high, pursuing those with muscle disease. If it's only mildly elevated, perhaps looking at SMA or myotonic dystrophy. Both of the patients with SMA, they have sponsored testing, no charge testing from Invitae Lab, which is easily accessible. Myotonic dystrophy is not included on panels or whole exome sequencing, so you would want to test that specifically, but they have very clear phenotypes that we'll go through more. If the CK is not elevated, or if it's elevated, but it is not easily found on your first round of gene testing, you may want to get an EMG nerve conductions test or do further muscle imaging. typically working with neurologists will help guide you in this. So infants with who are hypotonic, making the referral. Some suggestions are every state has a newborn screening program. They typically work closely with the Department of Genetics. And since we're now screening for SMA, they could identify who is the person in the state in your region who is seeing babies with SMA. And they're typically seeing neuromuscular disorders. You can also reach out to the Department of Genetics. They can tell you who is seeing people and receiving referrals for your region. Also, contacting your local MDA clinic, and there's a slide with those locations as well later. In general, pediatric neurology or genetics are a good place to start with referrals. So hypotonic children, so now stepping into the older category, their presentation and things that are red flags are this decreased muscle bulk. Sometimes you have to undress them to look at a proximal weakness because distally they may have good muscle, but proximal probably not. Do they have large muscles such as boys with Duchenne have? Scoliosis on exams and looking at their back. Looking at their foot, taking off their shoes to notice if they have a deformity of the foot, like foot drop or pes cavus foot deformity, and asking about swallow and breathing, which may be out of proportion to the weakness, so they may be able to walk but still have a lot of trouble swallowing or respiratory insufficiency. Again, some of the more common causes are central nervous system causes of muscle dysfunction, infection, or metabolic disorders. But if those are ruled out, you can move to the list on the right, which talks about lists of more common, as in this lecture, including Duchenne, myotonic dystrophy, SMA type 2 or 3, some of the congenital muscular dystrophies, and myopathies that occur in childhood.
Thank you, Dr. Caron. We'll proceed with some of the things which Dr. Caron has mentioned, going a little bit about individual disorders. We'll start with the most common disorder which we see in the pediatric neuromuscular clinic, the Duchenne muscular dystrophy. And the importance of this recognition is, so far we don't have a newborn screening program unlike SMA for this disorder. So we just really have to figure it out, and we need to sort of try to identify these children early, because there are, as we would go through, there are a lot of treatments which are available. So as we don't have a screening program, we have to be very vigilant about the clinical features, which will go subsequently. And there are very specific treatments for these children, including steroids. There are some exon skipping therapy, which is approximately 30% of children with DMD can benefit from that. And recently, just in June of this year, we have a gene replacement therapy, which is available for DMD children when they're between 4 and 5 years. And hopefully that age range can be expanded as in the coming years. So typically the onset of the children or the clinical manifestations are we see by 2 to 3 years, more with the gross motor impairment, where they have sometimes gross motor delays, toe walking, falling, etc. But sometimes we may see something which is more of a global delays, speech delays, signs of autism. So those are sometimes could be important to look for before they are clinically manifesting with significant weakness. And also sometimes they were checked the liver enzymes for unknown reason, and those found to be very high. And then sometimes they have an extensive workup to look for underlying liver disease, and subsequently turn out to be that those liver enzymes elevation are in fact coming from the muscles. So if the liver enzymes are very high in a child who does not have other symptoms of liver disease, we really have to think about Duchenne muscular dystrophy or some of the muscular dystrophies. In the early ambulatory phase, that's when we are talking about 2 to 3 and older children, you may see, as Dr. Caron mentioned, about hypertrophic muscle, particularly looking at their calves, where you would see a significant hypertrophy out of proportion to their general muscle bulk. Frequently, they toe walk. You can see some signs and symptoms suggestive of proximal muscle weakness, like difficulty climbing stairs, standing from a sitting position. We get family history or history from the parents that they are lagging behind their peers in terms of those running around or sort of just don't have that much endurance or energy. Since the dystrophin, unlike a lot of the neuromuscular disorder, this gene codes the protein dystrophin, which is seen in the in the central nervous system. Frequently, we do see these children have learning and behavioral problems, and that can be an early clue even before they developed muscle symptoms. And these are some of the very classic pictures which we see in patients with Duchenne muscular dystrophy. Now we have to recognize sometimes we diagnose children relatively early. Sometimes we may not see this classic phenotype or the classic picture, but we do always see some features of early DMD, where, as you could see on the extreme left, the child with calf hypertrophy as well as hypertrophy or well-formed muscle in the thighs. So that could be another feature in early recognition. So as Dr. Caron mentioned, undressing the child would be very helpful in identifying these different muscle phenotypes, particularly whether there is muscle atrophy or hypertrophy. In the late stages of DMD, as you could see, these children have significant lordosis as a compensatory mechanism for their proximal muscle weakness. In fact, as they get older, you would see that their muscle bulk are getting thinner. They have significant toe walking and contracted tendo-Achilles, as well as scapular winging. This is a very classic sign, which we all know, the Gower sign, where it is basically, it is not very specific for DMD. It's just suggests there is significant proximal weakness. So any neuromuscular disorder with a significant component of proximal muscle weakness of the hip girdles would similarly present with this maneuver, where, as you could see, when they're lying and then when they're asked to stand up, they would sort of turn around and face the floor, and then gradually, as if they are supporting themselves as they walk with their hands first on the floor, then on their legs, and then finally they're able to stand. Baker muscular dystrophy is on the spectrum of what we call dystrophinopathy. So it's in the milder spectrum of dystrophinopathy. The severe end is the Duchenne muscular dystrophy, and the mild one is Baker muscular dystrophy. They are Baker muscular dystrophy is less common than the Duchenne muscular dystrophy in general, but their course is very variable, and they can have very non-specific symptoms like exertional pain in their legs while they're doing physical activities. Sometimes this could be passed off as growing pain. So if the patient consistently complain of leg pain, which is somehow associated with exertional activities like running around, jumping, and those kind of things, playing in the park, then at least looking for this condition would be important. And CK, as we are highlighting throughout this presentation, the checking a CK is a very simple test, can be done in the office, and that can give a significant clue to this diagnosis. They do not, in this figure, we are seeing this child to be significantly weak, but they can be strong, and they can remain strong in their third, fourth, or fifth decade. So sometimes it could be a little deceptive just if we examine for muscle weakness for Baker muscular dystrophy. Now we'll talk about this, as Dr. Caron mentioned, as a group. Congenital muscular dystrophies and congenital myopathies as such are very rare, but you do see them in your practice. But there are certain clues which point towards this diagnosis, or at least thinking about a neuromuscular disorder. And some of those classical features are myopathic faces. By definition, they sort of, as you could see in these three children, they have kind of an elongated mouth with the mouth held open. They have high arch palate, and that's suggestive of significant facial weakness, as if they do not have a lot of expression in their facial when they laugh or other facial expressions. Their upper lips are usually tinted. Some can have associated weakness of the extraocular muscles, meaning they have ophthalmoplegia, ptosis. In general, they have very reduced muscle bulk, and they have this pattern of weakness, which we call limb girdle pattern of weakness. So when we see that they have the weakness of the shoulder girdle as well as the hip girdle, but relatively preserved distal muscle strength, that's when we are thinking about myopathies or anterior horn cell disorders like SMA. So among these rare disorders, there are some common ones, particularly collagen 6 related muscular dystrophies, which in the past we used to call as Ulrich or Bethlehem, but now it's basically broadly classified as collagen 6 related muscle diseases. LAMA2 related muscular dystrophy and dystroglycan related, and within that dystroglycan there are several genes which can cause different forms of specific muscular dystrophy. On the other spectrum, we have congenital myopathies where classically the CK or the muscle enzyme is normal. So it is important to consider this group of disorders when you see a patient has proximal muscle weakness on exam, significantly weak, maybe have some facial weakness, but their CK is deceptively normal because these muscles, these conditions typically do not injure the muscle membrane, because the proteins which are encoded by these genes, they are intracellular, so the muscle membrane is intact, and the CK is an enzyme which is within the muscle cell. That's why their CK are normal. So that's why it is important to consider this genetic disorder even if the CK is normal in an appropriate clinical setting. The next important group of disorder is congenital myotonic dystrophy type 1. Now, myotonic dystrophy type 1 has a wide range of presentation. It can present in the very early age, basically at birth, or in the prenatally, they have some features suggestive of prenatal weakness. Those are the severe end of the spectrum. Then you can see them in the childhood age or juvenile onset myotonic dystrophy. But in fact, it is the more common in the adult sort of life. So, so adult neuromuscular doctors see it very often but they have a relatively milder phenotype. So as you could see in this figure, different pictures, this child is very severely weak. And in addition to the weak, because they're very floppy and they have facial weakness, and we'll go over in the subsequent slide also, they have significant breathing and respiratory difficulty after birth, requiring some degree of breathing support or feeding support through NG feeding, or sometimes they may need gastrostomy tube insertion. So this is an autosomal dominant disorder, as Dr. Caron was mentioning, and it needs to be identified because this is a triplet nucleotide repeat disorder. So it's not in the common panels which we typically look for neuromuscular disorders. So unless we think about this condition, it would be missed. And particularly also more and more we are using whole exome sequencing in babies with neuromuscular disorders to identify a genetic cause. But unfortunately, with the current technology, whole exome sequencing would miss this. So this needs to be very carefully thought of as a diagnosis for congenital muscular dystrophy, and specifically genetic testing needs to happen. Now, almost always this is transmitted from the mother to the baby. So it is always important, and there is a saying that you need to examine the mother to make this diagnosis, because frequently the mothers may have minimal symptoms or even may not have been diagnosed with myotonic dystrophy. And because of this phenomenon of genetic anticipation in triplet nucleotide repeat disorders, these children with higher repeats present very early in life. And as we saw in the previous photographs, they have significant hypotonia, poor feeding, respiratory difficulty, and they have a very high mortality rate. So we really need to be careful about this diagnosis and figure this out. Juvenile onset have a little will be sort of a milder phenotype. They have may have delayed milestones. Significant learning and cognitive dysfunction is common. They have significant oropharyngeal weakness, so leading to dysphagia. They have characteristic facial weakness. So those are some of the features which help to sort of think about this diagnosis. And the late onset is most common presentation and have a milder form of the disease. So as you could see here, again, some pictures of the children with congenital myotonic dystrophy requiring significant respiratory or feeding support. And here you would also see a mom with the baby, and the mother has very minimal manifestation, but still at least you can appreciate some elongated facial appearance in the mom. When you examine the mother, you can see that they have a very classical features, like when you shake their hands, they have very tight grip and difficulty in relaxing their muscles, suggestive of clinical myotonia. So examination of the mother is very important to identify or suspect this condition. And these are classic facial features you could see in patients with a little older myotonic dystrophy. You could see very elongated faces, significant. They have some degree of ptosis, and also myopathic faces, tinted upper lip. All are the features which are very common in myotonic dystrophy. And this phenotype helps us to guide further genetic testing specifically for this particular condition. Limb girdle muscular dystrophy, as the name suggests, it's just the pattern of weakness. There has been several classifications. It goes back and forth. Every few years we get a few new genes. So to the point that we sort of exhausted all the alphabets, and now we have a different way of naming these disorders. They are all characterized by progressive muscle weakness and a limb girdle pattern, meaning typically the legs are weaker than the shoulders to begin with, but it is a progressive group of disorders. In children, so there are several types, and some present in adults, some in children, but in the children, when they present, the most common would be something as a group, we call them sarcoglycanopathies. That's a protein which is present in the muscle membrane. They almost kind of similarly present like a Duchenne muscular dystrophy present patient. But one important thing is, if you are seeing a child who is girl and at 5 years of age had proximal muscle weakness, very high CK, then you have to think of limb girdle dystrophy as the first diagnosis, rather than obviously Duchenne muscular dystrophy, which is X-linked. Other limb girdle muscular dystrophies which can present would be LGMD2I in the past. Now they're called R9. And the R and D stands for recessive and dominant disorder. And that's why these are autosomal disorders which can be dominant and recessive. And within this pattern, there are several of them. So it can be pretty confusing. So as a generally, when we are suspecting limb girdle muscular dystrophy, unlike SMA, unlike DMD, we typically send a gene panel which covers a group of disorders rather than a very particular gene, because unless we have a very specific family history, it's sometimes very hard to identify them just by doing a single gene test. And these are some of the classic pictures with on the left, you are seeing some features of a hypermobility of the joints, which can be seen in a group of disorders, classically congenital muscular dystrophies associated with collagen 6 mutations. Then you have on the right side a pattern of weakness where it is a limb girdle type of phenotype. And as you could see in the child, we are seeing the legs on the extreme right and lower corner. You could appreciate significant calf hypertrophy. So just highlighting the point that calf hypertrophy is present in other muscular dystrophy, and it does not have to be only Duchenne muscular dystrophy. So next we'll move on to a group of disorders collectively called Charcot-Marie-Tooth disorders, which are a group of genetic neuropathies, and there are several genes, almost approaching 200 plus genes in this disorder. They classically present, the most common one is CMT1A, which accounts for about 50 to 60% of all the CMTs. They typically present in the first or second decade of life, and there the rate of progression is very, very slow. So they typically present with some feet deformities in the form of high arches, but rarely we can see flat feet also. They could have hammer toes. These basically suggest an imbalance in the muscle strength. Distal muscles are weak and atrophic, and then there is an interplay between the ligaments and the weak muscles, and that's how their feet deformities take place. They classically have distal muscle weakness, unlike the muscular dystrophies, which present with the proximal weakness. So they sometimes present with foot drops, tapage gait. They have eversion weakness, so they frequently over-invert their foot, leading to frequent tripping, falling, difficulty in walking. Unlike muscle disorders, which is a motor disorder, this group of disorders affects the motor and sensory nerves. So that's why on exam we can find evidence of sensory loss in a pattern which suggests the distal muscles. In the distal extremities. And also another important feature which helps to differentiate this group of disorders from muscular dystrophy in the early phase, their reflexes or tendon reflexes either reduced or absent, whereas in muscular dystrophies or genetic myopathies, classically they are normal or preserved in the early phases. And here you would appreciate on the left what is significant atrophy of the distal third of the legs, to the point they have been classically described as inverted champagne bottle appearance, meaning very distal lower extremities. And as we go to above the knee, they're more almost looking relatively normal. And as you could see, some hand deformities, and very classically on the extreme right, you could see the high arch or the pes cavus, with also appreciate some hammer toes or clawing of the toes. So workup, as Dr. Caron has mentioned previously, when we are looking at this phenotype, the test which we can do very quickly in the office is muscle enzyme. If it is more than 1,000, that's definitely we have to be thinking about a genetic muscle disease, but we always have to keep in mind a normal CK does not rule out neuromuscular disorders. Muscle diseases also can have normal CK, just they are more rare, but still it is possible. More specific testing looking for EMG nerve conduction and ultrasound or MRI could be helpful, but they are not done as the first year testing. If the phenotype is very classical, say a 3-year-old boy with motor delays, big calves, and positive Gower sign, then we are thinking about DMD, then we can straight away go for the single gene test. Whereas if the phenotype is not very clear and the history is, or the family history or the exam findings are not very clear, then we can go for a more broader gene panel. A genetic counselor could be very helpful in identifying and choosing what specific genetic test would be helpful in identifying the condition for a specific patient. So some special considerations, as we have discussed in the previous slide, particularly we are talking about spending some time about dystrophinopathies or DMD, because this is among the muscular dystrophies. At this point, this one has specific treatment, and sometimes they could be missed in the early phases because the clinically manifest weakness may not be apparent by 2 to 3 years. And in autistic boys, sometimes exam could be challenging. So at least thinking about this condition, if a child presents with even global developmental delay autism spectrum disorder, checking a CK could be very helpful to at least screen this condition. So this is sort of a slide, gives you a broad sense. If you check a CK and then you look back to the patient, and if you have high CK and proximal weakness, then you can sort of go to two pathways. One, muscular dystrophies, usually the history is chronic, meaning going for months to years. They could have some family history, calf hypertrophy, and then within that category, you have different types. The most common in boys would be dystrophinopathies. Typically, CKs are very high. Limb-girdle muscular dystrophy are of many types, but again, you have to think about this. If you're seeing a girl with proximal weakness and high CK, congenital muscular dystrophies are usually early onset disorders, meaning they present typically in the first 2 to 3 years of life with obvious muscle weakness. There may be certain characteristic appearance, say facioscapulohumeral muscular dystrophy. As the name suggests, there is a specific pattern of weakness in their facial muscles or periscapular muscle. Myotonic dystrophy, as we talked about, and then very rare congenital myopathies where the CK can be normal. On the other hand, if we have a patient with a relatively subacute onset, few weeks to months, then I think we have to at least think about the inflammatory myopathy, of which in children we always have to think about dermatomyositis. If they have the characteristic rags, then the diagnosis is relatively straightforward. But if sometimes the muscle weakness could be there, or the rash could be not that severe, so this condition needs to be always considered because it has a very specific treatment with high-dose steroids and other immunosuppressive agents. Now, if we have a child who have high CK but normal exam, then we think about certain metabolic myopathies where they can present with recurrent episodes of muscle breakdown or rhabdomyolysis. We can do a very complex set of labs to identify those group of disorders. So next we'll go over some vignettes, and the first vignette will talk about a 5-year-old girl with proximal muscle weakness, and basically parents came to us with the gross motor skill, concerned with her gross motor skills, as intermittent falls, could not run well, and on exam has positive Gowers, and when we check the CK is very high. So with this phenotype, what are the things which we consider? So the correct answer is limb-girdle muscular dystrophy, which people have most of who have answered responded with the correct identification. So for the interest of the time, for subsequent slides, we may just go through them relatively quickly so that we may have something at the end to discuss. A 2-year-old boy with delayed walking, frequent falls. There is a family history of maternal uncles with muscular dystrophy, just highlighting an X-linked kind of inheritance pattern with an elder sibling with motor delays, calf hypertrophy, proximal weakness, and CK very high. So with this, we did the genetic testing and ultimately turned out to be Duchenne muscular dystrophy. With this, the reason for putting this case up is just to highlight the X-linked form of inheritance. So this family history is very helpful with another older sib having similar presentation. We'll go to the next slide. So 4-year-old boy presents from the GI clinic with AST, ALT in the range of 300 to 500, but other normal liver functions. On history, the milestones are fine, but this boy on exam had calf hypertrophy, mild proximal leg weakness, and the CK is very, very high. So with this phenotype, again, we have to think about Duchenne muscular dystrophy. And this case highlights that sometimes we get referral from the GI clinic with very high CK. And this individual child had a specific mutation, and they could be amenable to one of the exon skipping therapies. So that sort of highlights the importance of doing genetic testing or finding the specific mutation so that we can help these patients with the management. So this is a 7-year-old boy who presents with exertional leg pain, mostly affecting the calves, normal gross motor milestones, but again on exam had a calf hypertrophy and subtle proximal leg weakness. A CK is high, but it is not as high as we would expect in Duchenne muscular dystrophy. And the genetic test confirmed Baker muscular dystrophy, just highlighting that they are on the milder spectrum compared to Duchenne muscular dystrophy. So a 13-year-old girl presents to the neurology clinic from orthopedics due to tight heel cords, some floppiness as an infant. Motor milestones are kind of normal, started toe walking at 2 years, had some facial weakness, sleeps with eyes open, had speech delay, and some autistic features. And with this, the presentation is kind of little non-specific, doesn't fit exactly with our muscular dystrophy, but with this story and some facial weakness, at least we have to think among these choices about myotonic dystrophy. We haven't given a picture here that would have been more clear, but at least we have to think about myotonic dystrophy as a potential diagnosis in this case. Now, this is a 6-week boy who presented to the ER with severe weakness. Things were normal at birth, but subsequently, after 3 weeks, parents noticed that the boy is just not moving that well. And then on exam had significant weakness of the legs as well as the trunk. Reflexes is difficult to elicit. And this would be a very classic presentation of spinal muscular atrophy because they have the CK is normal, but they have a very expressive facial appearance, which distinguishes them from some of the other conditions. And this is a disorder which the current treatment has sort of changed the time course, how we see these patients, and has revolutionized how the care of these babies. And I think we have maybe that this we can do as the last vignette as symptoms noticed around 9 to 10 years with some considerable difficulty in walking, high arch feet, very strong family history suggestive of autosomal dominant inheritance, and then subsequently genetic test confirmed the diagnosis of Charcot-Marie-Tooth disorder. So we can skip the last one and go to the summary slides. So overall, we would like to give a message that neuromuscular disorders, there are different types. Some of them have intervention available in the forms of treatment which can change the outcome. So that's why we want to diagnose these conditions early. So frequently they come in the primary care setting, and that's when we hope to get some testing done and early referral so that we can diagnose these conditions. Early screening with creatine kinase is a very helpful tool, at least to rule in and rule out some specific muscular dystrophies. And then we would like to do certain genetic screening or testing to sort of get to the specific diagnosis. So these are some of the red flag symptoms for floppy infants: frog leg posture, reduced muscle bulk, limb girdle pattern of weakness, loss of reflexes, and then looking at facial, bulbar, and other types of weakness. Whereas in older children, similarly decreased muscle bulk, not only muscle atrophy, but also a pattern of muscle hypertrophy, looking for other skeletal changes like scoliosis and high arch feet, and then looking for bulbar weakness or respiratory muscle weakness. So these are some of the resources which could help to guide us. And we have a lot of slides from Victor Dubowit's book of Color Atlas of Muscle Disorders, which shows the very classical presentation. So again, the helpful tools: creatine kinase testing early would be very cheap and easily available test. Early referral would help in identifying an exact diagnosis. Partner with our local MDS center, and the childmuscleweakness.org is a very useful video tool to look for different videos and algorithms which can guide in different type of neuromuscular disorders. And I think I'll end here.